Let's study now the Doppler evaluation of the systolic function of the left ventricle. One of the methods to evaluate the left ventricular systolic function by Doppler is using the Myocardial Performance Index, MPI, also called the TI index. The MPI has information from the systolic and diastolic functions. It is the sum of the isovolumetric contraction and relaxation times divided by the ejection time. It is obtained from a Doppler mitral flow and left ventricular outflow. As the left ventricle function deteriorates, also does its relaxation, what increases the isovolumetric relaxation time, IRT, corresponding to the period between the end of the ejection to the beginning of the mitral flow. The same happens with the isovolumetric contraction time, ICT, corresponding to the period from the end of the mitral flow to the beginning of the ejection. However, the ejection time of the left ventricle decreases as its function deteriorates. Hence, the TI index will be abnormal as it increases more than 0.40. We can measure it by taking the systolic time from the end to the beginning of the mitral flow, then divides it by the ejection time. The TI index relates to the ejection fraction by this regression equation. Lax et al. Proclaim it to be helpful in patients with reduced echo images. It is said to have prognostic value and to be simple and reproducible. However, its paper demonstrates the correlation of this index with the ejection fraction obtained by nuclear medicine, where you notice the large dispersion of the data. Here we see the Blend-Altman graphic of Lax et al. On paper. It shows that this kind of dispersion prevents the utilization of the TI index in the clinical scenario. Why is that? Because when we are using this index in our patient, we are interested primarily in two levels of ejection fraction. For instance, is the ejection fraction normal or abnormal? Let's say at the 5th percent level. Notice that if the ejection fraction that we get by this TI equation is 50%, it may indeed be somewhere between 37 to 60%. Then how can we know at what level is the patient we are studying? Is he or she normal or abnormal? Another level of ejection fraction that is very important is 35 for resynchronization therapy. Notice that a patient with 35% that we may be studying using this index, he or she may indeed have an ejection fraction between 22 and 45, and we do not know where the ejection fraction is. There is a horrible concordance. This method is not only badly accurate, but also lacks precision. I do not recommend to use this index. Another Doppler method is the DP-DT. What is it? It is a method coming from the heart catheterization to analyze left ventricular function by measuring the maximal instantaneous velocity of the left ventricular pressure increase. Then, it is an infinitesimal calculus, a derivative of pressure and time. Then, if we see a mitral regurgitation flow, it could represent a pressure curve of the left ventricle, since this is a velocity curve that indicates gradient between the left ventricle and the left atrium. Then, with increasing velocity of the pressure in the left ventricle, there will be an increased velocity of this regurgitation flow. We measure the time interval between the velocity of 1 meter per second, corresponding to a gradient of 4 millimeters of mercury, to the velocity of 3 meters per second, corresponding to the gradient of 36 millimeters of mercury. It would be the time delay to increase this difference of 32 millimeters of mercury of the gradient. Then, the dp/dt would be the time delay to increase this difference of 32 millimeters of mercury of the gradient. By dividing this gradient to the time delay, the result is the so-called by several authors as dp/dt, or the derivative of pressure and time. Here is an example. There is a mitral regurgitation, and we know that the worse the left ventricular systolic function, the slower the velocity of gradient increase between left ventricle and left atrium, and more time will take it to increase the gradient from 1 to 3 meters per second, corresponding to a gradient difference of 32 millimeters of mercury. By dividing this difference in gradient by this time, in this case here 45 milliseconds, we have the so-called dp/dt of 711 millimeters of mercury per second. Normal value is more than 1200 millimeters of mercury per second. Borderline of 1000 to 1200 millimeters of mercury per second, and abnormal if less than 1000 millimeters of mercury per second. To begin with, the problem with this method is one of concept. One should not call this dp/dt, or derivative of pressure related to time. As shown in the first period of this talk about infinitesimal calculus, this is not dp/dt, since the pressure nor the time are infinitesimal. Furthermore, we measure velocity that may be considered a gradient, not a pressure. What we are measuring is a delta G of gradient, a difference of gradient, related to a difference in time, or delta T. This is not even dg/dt, or a derivative of gradient and time, since these measurements are not instantaneous. However, the problem is not only of calculus misconception. Since we do not measure left ventricular pressure but a gradient between the left ventricle and the left atrium, the regurgitation curve is not solely dependent of the left ventricular pressure, but also of the left atrial pressure and compliance. And this is not taken in consideration here, and hence also dependent on the left atrial compliance, which can be quite variable. Not a good method, not accurate. Furthermore, it is only abnormal when there is an evident left ventricular dysfunction. The better way to analyze left ventricular systolic function using Doppler is to evaluate left ventricular ejection volume and then the cardiac output. Just reminding you that Doppler does not assess volumetric flow, just flow velocity. It does not measure directly the amount of liquid that is passing through this tube during a specific time, only its velocity. To obtain a volume of the left ventricular ejection or cardiac output, it is necessary to know the velocity of blood about the circular area where it is passing. When we have an area where the blood is going through in a square centimeter and multiply it by its velocity in centimeter per second, then we have volumetric flow in cube centimeter per second. Also, just a reminder of how to calculate the volume of the geometric figure of a cylinder. To get its volume, we must know the area of its base and multiply it by its height. To calculate this area, it is necessary to know the diameter of the base, circumference. Half of this is obviously the radius. Then the area will be pi times the square radius times the height. How are we going to evaluate by Doppler this ejection volume? We will consider that the left ventricle ejected blood in a single systole will be inside the aorta in a region that we could believe it is a cylinder. Then we must calculate the volume of this cylinder if we have its basal area and its height. The basal area is the area of the circumference formed by the diameter measured from one aortic cusp insertion to the other. In other words, pi times the square radius. The height of this cylinder is the velocity time integral of the left ventricular outflow tract Doppler flow. If you do not know how from a velocity curve we get a distance using the integral, please watch the video class in the first period. Then, basal area times the left ventricular outflow tract VTI, we have the volume of this cylinder. Then, to calculate the left ventricular ejection volume, we have initially to measure in a parasternal long X the distance from the insertion of an aortic cusp to the other. Pi squared radius of this range will give us the area of the left ventricular outflow tract. Now we need the height. From an apical 5 chambers or an apical long X, we will set the cursor and the pulse wave Doppler sample volume right where we measure the area. In other words, at the left ventricular outflow tract, right close to the aortic cusps. In this place, we obtain the left ventricular outflow tract velocity. If the pulse wave sample volume is in the correct position, right close to the aortic valve, but inside the left ventricular outflow tract, in the trace there must be a closing click of this valve. With the planimetry of this velocity curve, we'll obtain the VTI, velocity time integral, in centimeters. That corresponds to the distance the blood will travel if it follows this velocity curve. Area of the base times this height will give us the ejected volume. The ejected volume times the heart rate is the cardiac output. However, we have some problems with this evaluation. As we have seen, an integral is obtained from a derivative curve of a velocity. However, at the outflow tract of the left ventricle, there are several different velocities because of the septal curvature. Close to the septum, they are higher than away from it. This is demonstrated by a color Doppler of this region that always shows different levels of aliasing. Then our measured VTI will depend a lot not only on the distance of the post-wave sample volume from the area of the outflow we have estimated, but also where is the sample volume relative to the IVS. It is not a question only of measurement, but also the fact that you cannot take any velocity to represent the VTI, since we're talking about volume here, and it is only accurate if the whole blood volume were moving with a single velocity. In the left ventricular outflow tract, we do not have a flat front of velocities where all are equal, as seen here. In this situation, if our sample volume were here, for instance, and taking the VTI of this velocity, its VTI would be the same for all others' velocity and an accurate height of the cylinder, and hence of the whole volume of blood ejected. The problem is when the flow has not a flat front, but it's like this sinusoidal flow here, or worse yet, a flow is skewed towards higher velocities closer to the IVS. Depending on which left ventricular outflow tract location we are setting the sample volume, the velocity we take will be different. The VTI will also be different, and so the height of the cylinder and the volume of the ejected blood. Here an example. Let's evaluate the ejection volume in this patient. The first thing to do is to measure diameter of the left ventricular outflow tract, right beneath the aortic valve. From the diameter, we get the radius. Pi times the square of the radius will give us the area of this region. Now let's get the flow right in this place to analyze the VTI. Then we have to go to an apical 5 chambers. Notice how the flow in this region does not have a flat front. There are regions with higher and lower velocities. Any velocity that we take here will not be representative of the whole subaortic region. See here, we are in the right place. Watch the closing click of the aortic valve as recommended by the American Society of Echo. The planimetry gave us a VTI of 24.4 cm. Now we repeat just a few seconds apart with the sample volume at the same depth in the left ventricular outflow tract near to the aortic valve, as can be seen by the closing click, just not as close to the IVS. The measured VTI is 20.2 cm. These are the results using the same diameter we have measured at the left ventricular outflow tract, and these two different VTI of the same region. We may have a 20% variation of the ejection volume in this patient evaluated in less than 1 minute apart. In this case, it was straightforward to measure the diameter of the left ventricular outflow tract, and we keep the same value for both evaluations of the ejection volume. However, most mistakes occur in this diameter measurement. Most of middle-aged or older patients have calcified aortic valves or angled left ventricular outflow tract, which turns this measurement quite tricky. an error here will be squared. Then, if we increase or decrease just 1 millimeter of our encountered value of 2 centimeters, the mistake will be 47% from one measurement to the other. Again, the blend Altman graphic showing the concordance of the cardiac output measured by Doppler echocardiography and by right heart catheterization. Notice that if you find a value of 5 liters per minute by this method, it may indeed be anywhere between 2.8 to 7.2 liters per minute. Is it possible to use it clinically? That's my question.